28. Medicine personalized. When treatment finally started looking like the patient. The prediction, what we thought. As the human genome came into view in the late 1990s, medicine made a confident promise. Treatment would become personal. Drugs would no longer be one-size-fits-all. Therapies would be tailored to an individual's genetic makeup, metabolism, risk profile, and likely response. Doctors would stop guessing which medication might work and start knowing which one would. In this future, side effects would shrink, effectiveness would rise, and prevention would become as important as cure. Medicine would shift from population averages to individual precision. Standing in 1999, this felt like the obvious payoff of decoding DNA. If disease lived in genes, treatment would follow. Why this prediction made sense in 1999? The optimism rested on a powerful idea: genes explain difference. In 1999, the Human Genome Project was nearing completion. Genetic testing was becoming feasible. Researchers were identifying disease-linked variants. Pharmacology was grappling with uneven drug responses. Doctors already knew that patients responded differently to the same treatment. Some benefited. Some didn't. Some experienced severe side effects. Genetics appeared to offer a unifying explanation. If doctors could see those differences in advance, medicine could become both safer and smarter. This belief aligned perfectly with the millennium-era confidence that science was moving from blunt instruments to precision tools. Surgery had become minimally invasive. Imaging had become detailed. Diagnostics had become sophisticated. Treatment felt overdue for the same refinement. For younger readers today, it's important to remember how crude many treatments still felt in 1999. Trial and error prescribing was common. Adverse reactions were frequent. Personalized medicine promised dignity as much as efficiency. Who said it, and where? The intellectual and institutional driver behind this prediction was the Human Genome Project, whose public messaging in the late 1990s emphasized individualized treatment as a core future benefit of genomic knowledge. Scientists and policymakers described a world where genetic profiles would guide prevention, diagnosis, and therapy. The rhetoric was careful, but the implication was clear. Medicine was about to become deeply personal. Unlike some predictions in this book, this one was not speculative futurism. It was framed as a design goal of modern medicine. What actually happened 2000 to 2025? Personalized medicine arrived, unevenly, but decisively. The early 2000s delivered genetic testing and risk assessment. Certain cancers began to be treated based on tumor genetics rather than location alone. Drug dosing improved for specific populations. By the 2010s and 2020s, pharmacogenomics guided medication choice and dosage. Cancer therapies targeted specific mutations. Genetic screening informed preventive care. Treatment decisions incorporated lifestyle and data profiles. Medicine did not become perfectly individualized, but it became meaningfully stratified. Doctors moved from guessing to narrowing. Patients received treatments better matched to their biology. By 2025, personalized medicine was no longer a buzzword. It was embedded in oncology, cardiology, rare disease treatment, and preventive care, not universally, not flawlessly, but unmistakably. The prediction's core promise, that treatment would increasingly fit the patient rather than the average, was fulfilled. Verdict. Status. Realized. Personalized medicine is now a standard part of modern healthcare. Genetic information, biomarkers, and individual risk profiles routinely guide treatment decisions. The prediction succeeded in direction, substance, and impact, even if its rollout was gradual. Why it played out this way? This prediction worked because it matched medical reality. Human variation matters. Ignoring it was inefficient and sometimes dangerous. Once tools existed to measure differences reliably, medicine had every incentive to use them. What slowed progress was not resistance, but complexity. Genetics explains some differences, but not all. Environment, behavior, and chance still matter. Personalization turned out to be multidimensional, not purely genetic. Still, the shift was irreversible. Once doctors could see why treatments worked differently across patients, there was no going back to averages alone. What this prediction teaches us about the future. This case highlights a powerful forecasting principle. Predictions that refine existing systems tend to succeed faster than those that replace them. Personalized medicine didn't overthrow healthcare. It improved it incrementally. It worked within existing institutions, incentives, and ethics. In 1999, it symbolized a medical revolution. In 2026, it feels like common sense. The future delivered not perfection, but precision. One sentence takeaway. We stopped treating patients like averages and started treating them like individuals.